Okay, we are live, and we'll get started here in just a second. Let me put a little Twitter post up. And you guys feel free to share this on your ends, too, once you see it come out. Should be popping up here any second. This is what happens when you have two computers and a phone running at the same time. There we go. Yep, it's live. Okay. And Marissa, I'm going to put you into the stream. You're not going to be on screen just yet, but you are on deck to start. Okay. And it looks like Eric's already watching too, so Eric's going to be watching your poster presentation. That's good. I think he's taking credit for the title, but I'm not sure. Marissa, we'll see.
He definitely is.
Okay, well, let's get started. Welcome to the American Society of Regional Anesthesia and Pain podcast as a wrap. I'm your host, Raj Gupta, coming to you from Nashville, Tennessee. Well, we are on our 6th day of presenting posters for the American Society of Regional Anesthesia 2020 spring meeting that never really happened. So the meeting got canceled, but we had all these wonderful posters, so we thought we'd share them with you. And we had a great time last week. Really good response every day. We had almost 1,000 viewers every day for the shows last week within 24 hours. And the response was so good, we realized there was one big topic we left out. That's a prominent topic at the spring meeting these days, and that's point-of-care ultrasound. So we wanted to make sure we included the abstracts for point-of-care ultrasound, and we have a tremendous group of people to present these topics with and moderate it. But more importantly, we have 6 of our posters are going to be presented by some of the authors of the posters, which is really great because they didn't get a chance to present their posters at the meeting this year. We're going to have all of them up here in just a second. Let me get the team up here on the screen. So, hello. I'm going to just have everybody wave. They can see your names at the bottom. I'm going to unhide this little dongle so they can see Steve's name too. And if you guys are watching, put comments in your comment area, and I will see those up here and include them when we get to that part of the conversation. We're going to start with our first poster presentation here in just a second. We've got lots of really good content, so we're going to kind of stay on a tight timeline. I'll include the other authors as we go, but I think it'll be a wonderful session. One quick note for those of you guys, while the author is presenting, try to mute your microphone just so we reduce the background noise. And then when we get to the Q&A, we can open up those mics. Okay, Marissa Weber is our first presenter, and she is going to be presenting poster number 806. And I will, for those of you guys are watching, I'm going to put the link in the comments field so you can follow along with the poster. And this poster's titled Pulp Fiction, a point-of-care gastric ultrasound analysis of the gastric emptying time of orange juice with and without pulp. So no comments about which you prefer, but Marissa, go for it. You're starting out today.
Alrighty. Good afternoon. My name is Marissa Weber. I'm a CA3 at Thomas Jefferson University. And we again did look at the presence of pulp in orange juice and whether that did affect gastric emptying time. As our poster seems to indicate, this is indeed a myth. So just a little bit of background information about fasting guidelines. So they've existed since the 1800s after a number of postoperative deaths were linked to intra-op aspiration. And as we're all aware, as anesthesiologists, induction is one of the most dangerous times in the anesthetic course. And the Royal College of Anesthetists actually remarked that 50% of deaths related to airway complications were actually linked to aspiration. So in terms of our current fasting guidelines, these have been put together after years of expert guidance. And they're as follows: 2 hours for clear liquids, 4 hours for breast milk, 6 for non-clear liquids like milk and orange juice with pulp, and 8 for large fatty meals. Again, this is based off expert opinion, not necessarily based off science. And in fact, it was shown when Van de Putte showed with his colleagues that 6.2% of patients showing up for elective surgery had stomach contents that were not consistent with a fasted state. So even if people do follow these guidelines appropriately, that still is not a guarantee that they will not have an aspiration event intra-op. So in terms of the 6-hour window, this Hilliard and his colleagues in the UK did address whether adding milk, a liquid that is considered to require a 6-hour fasting window, to tea would increase gastric emptying time. And they found that there was no change in subjects who drank tea with and without milk. So we were curious if the same applied to another one of the beverages that fits into that category, mainly orange juice with and without pulp. So in terms of our study, we recruited medical students from Thomas Jefferson University. We started with 13 medical students. You can see their demographics on a table in the bottom left of our poster. They, as you can tell, were young by and large, and they were otherwise healthy with BMIs of 22. So a little bit of information on gastric point of care ultrasound. We used the curvilinear probe to assess for gastric point of care ultrasound in the right lateral decubitus position. We found the gastric antrum by looking at the aorta and the SMA. And from there, you could assess the stomach itself. It's said to have a bullseye appearance, and we were able to qualitatively assess it, look at whether the stomach appeared to have anything in the contents. And you can see what that would look like. There's a picture on the top right of the fasted stomach. So you see that bullseye, and you can, looking at the stomach, can see that it doesn't really look like there's any contents. And you can also measure the gastric cross-sectional area as a quantitative way of assessing gastric volume. And what's kind of been determined is less than 1.5 milliliters per kilogram is consistent with a fasted state, because there are normal gastric secretions that will be in the stomach. So again, we recruited 13 medical students. They arrived after fasting for 8 hours. They underwent a preliminary screening, which ensured that they were indeed fasted. So we evaluated their gastric cross-sectional area and took pictures that would be evaluated by a blinded observer. They then drank 11.5 ounces of orange juice with and without pulp, and a timer was set for 120 minutes. After that time was up, they were rescanned, pictures were taken, and the cross-sectional area was measured. These were again evaluated by our independent observer. And you can see these pictures at the top right one again. So in terms of our results, we started with 13 patients. 3 were removed, 2 because of difficult anatomy, 1 because they had a pre-orange juice scan. So their initial scan in the morning when they were supposed to be fasted with a gastric volume greater than 1.5 milliliters per kilogram, so not consistent with a fasted state. And again, these images were evaluated before and afterwards. And as our data showed, before and after, the gastric volumes for these 10 patients were less than 1.5 milliliters per kilogram, again, showing no change in gastric emptying after drinking orange juice with and without pulp. So just in general, as we kind of discussed at the beginning, a lot of these guidelines we use have been reassuring to us. They were developed by expert opinion, but they are just one tool we've developed to help manage the aspiration risk that is associated with the general anesthetic. But with the development of ultrasound, we're able to hone in more on what appropriate guidelines really should be. And as our study seems to indicate, and other studies have indicated, beverages like milk, beverages like orange juice with pulp do not necessarily require the full 6-hour fasting guidelines. And orange juice with pulp should be treated like a clear liquid.
Thank you, Marissa. That was excellent. I'm going to give first dibs to this Q&A session to a co-author of yours, Dr. Haskins. Steve, you want to comment anything or ask a question? I assume that you know most of the answers to the questions, but you can comment first and then we'll move on. And you're still muted, by the way. There you go.
Yeah. Well, I was fortunate to be asked to participate in this study. I reviewed the images and was one of the people who gave feedback on whether it was empty or insight into whether or not quantitatively there was a significant amount of volume in the gastric contents. I mean, I think what this demonstrates is you know, that we could probably do countless studies along these lines when it comes to, you know, looking at chicken broth or looking at, you know, other elements that we're always sort of worried about, chewing gum, whatever it may be. But it highlights an important fact, which is when it comes to sort of healthy patients like that with low risk of a delayed gastric emptying, you know, they're most likely going to push things through like these clear liquids. It's unlikely that they're going to, you know, be a high risk for aspiration. And it again sort of points out that gastric ultrasound, thinking about Rochelle Cruselbrink's and Anahi Perlas's publication in ANA in January back in 2019, which looked at the pretest probability of whether or not the stomach is empty or full. And if there's a high pretest probability that the stomach is full, or there's a low pretest probability that the stomach is full, then the benefit of gastric ultrasound becomes relatively minimal. It's when you find that patient, that true 50-50% chance that they could be empty or full, that patient with diabetic gastroparesis who may still been fasted for 8 or 10 hours, or that patient with critical illness, that's when it really benefits you, because the sensitivity and specificity goes to almost 100% for gastric ultrasound. So I think this is a meaningful study because, again, it sort of highlights the difference between guidelines and clinical reality. But when it comes to utilizing gastric ultrasound, you don't necessarily need to scan every healthy volunteer that comes in who may have had a little bit of pulp, but it really does make a big difference for those patients where there's that true 50-50 chance that they may you know, have residual contents.
Melissa, I'm going to direct the next one, next opening here for you. If you have a question for Marissa, but one of the questions I had was related to what Steve was talking about, which is how often do you use the gastric ultrasound? Is it every patient with high suspicion? Are you guys utilizing it on any kind of regular basis, Melissa?
So in my practice, I actually incorporate it quite frequently. I do a lot of high-risk endoscopy, at least in pre-COVID times. Mm-hmm. And I find that that's actually one of the easiest places for me to incorporate its use, because I see a lot of questionable patients coming in that are having EGDs with histories of gastroparesis. And so while I can't say we are routinely using it, I certainly do use it with this significantly increased frequency in that specific patient population.
Any questions for Marissa on her poster?
Thanks, Marissa. Did you change your clinical practice based on the study at your place?
I think we're starting to. It's just a lot of, I think like anything, it requires a lot of practitioners being comfortable with doing this. So it's something that our regional team is certainly very comfortable with. And I think it's especially effective for a lot of patients with, as you're saying, questionable NPO status, and some of our kind of higher risk patients. But it's, you know, it takes time, I think, for everyone to become comfortable with this to the point that it might be something that'd be more widely incorporated.
Well, can I add, as someone who's reviewing the images, the images from the beginning of the study to the end of the study, there was dramatic improvement in terms of what they were capturing. And I think there was a pretty gradual, well, not significant learning curve. They were able to, within, I would say, a few scans, really start getting excellent images. So it speaks to the ease of learning gastric ultrasound.
Yeah, much like a regional anesthesia, when we were doing ultrasound, the learning curve was pretty steep as far as acquiring images. Seems like with point of care ultrasound and gastric being one of the more straightforward ones, seems to be a very rapid learning curve. Marissa, I want to thank you for joining us and presenting your great work here. And I'm going to actually kick you off
Good
Thank
job.
you,
the
Marissa.
stream.
Thank you for having me.
Yeah, you're welcome to continue watching just because we have another person trying to log in here. And Rahul, I'm going to get you on here in just a second. Hey, and you're perfect. Welcome, Rahul. How are you?
Good. How are you?
Thank you for joining us and waiting for your presentation. Let me pull up your poster. And for those of you guys who are watching, this is point of care ultrasound. Oh, actually, let me start with this way. This is poster number 1041. And I'm going to put the link here in the comments. And I will put your poster up on the screen. There we go. And it's your turn. Go ahead, Rahul.
Okay, perfect. So my name is Rahul Guha. I'm an anesthesiologist at the University of Illinois at Chicago. And this is a case where we use point of care ultrasound to diagnose or evaluate severe intraoperative hypotension. So just a little bit of background. As we've talked a little bit about already, point of care ultrasound helps you find images in real time, which can help you do things like look at cardiac pathology, pulmonary pathology, gastric emptying. So it had a great application for us in this case. So this patient was a 65-year-old female who had a history of hypertension and had multiple lumbar surgeries and had a chronic back pain. So she was having another lumbar surgery to take out hardware and to do a lumbar fusion. The start of our case was pretty uneventful. We had an induction with propofol and succinylcholine. Intubation was no problem. They were doing neuromonitoring, so we started propofol and remifentanil infusions. We placed an arterial line after induction, and then we turned the patient prone, and the surgery started. So really no issues at the start. About 2 hours into the case, we had the blood pressure suddenly dropped and went down to about the 40s, 50s systolic, and it had been stable throughout before. We treated this with epinephrine, phenylephrine, lots of vasopressors to try to get the blood pressure back up. The episode lasted probably about 2 or 3 minutes, and then suddenly the blood pressure stabilized. We had an epinephrine infusion for a little while, but we were able to titrate that off pretty quickly. But we had this case of unexplained hypotension. After discussion with the surgeon, we said that we should try to stop the case as soon as we could so that we could try to work this up further. The surgeons had taken out the hardware, but they hadn't done any of the fusion yet. So they went ahead, just closed the incision. We turned the patient back supine. And this was where point of care ultrasound really helped us. So we brought the ultrasound into the operating room and we performed a few exams, but one of the things we looked at was the heart using a transthoracic echocardiogram. We tried a few different views, and the best one we had was the subcostal 4-chamber view. That's the one where you place the probe on the xiphoid and you angle it towards the left shoulder. And then you can see the images on the bottom here. So the image on the left is the image we had. The one on the right is just there as a reference. But if you look at the image on the left, that's the one we had. So you can see that we've labeled the right atrium, right ventricle, left atrium, and left ventricle. And then in red, we've kind of indicated what we saw as a hyperechoic mobile mass within the right atrium. So we presume this to be a cardiac thrombus. And it was really helpful to us to have this image because we had called cardiology and we were able to show them this image, and that really helped expedite care for the patient. We went over to the recovery room with the patient still intubated, and cardiology came down right away, and they did transthoracic and transesophageal echocardiograms. Interestingly, they didn't see the intracardiac thrombus. What happened most likely was that the thrombus propagated because the patient had a CT done a few hours later that showed left-sided pulmonary emboli that were submassive. So I think this case is a really good highlight of how you can use point of care ultrasound to make diagnoses in real time and expedite care for the patient, because this was the only time we saw the cardiac thrombus. And even by the time cardiology got there and did their exam, the thrombus was no longer present. We are, as providers, many of us are very used to using ultrasound perioperatively for things like regional techniques or vascular access. But hopefully by showing cases like this and by continuing to educate, we can expand the use of point of care ultrasound in the perioperative setting.
Excellent, Rahul. Thank you so much. We actually had talked about this poster earlier last week. We didn't have a chance to get you guys on. That's why I wanted to, I was excited to have one of you guys present this. Honestly, most of us, when we started reading this poster, we're trying to figure out how you did the ultrasound prone while the patient was still upside down, until we realized that you flipped the patient before you did that.
Right, exactly. We'd have to be really skilled to
yeah, I was trying to figure that out. Jan, I'm going to start with you. Any questions about this utilization of cardiac transthoracic echo intraoperatively for obviously an acute change in the patient's condition?
Yeah, no, I mean, it's just another fantastic example of the power of POCUS. I mean, I can see, everybody, even if they're not nodding their heads there, these are just, it's one of those things, where you help guide a patient's therapy and probably save their life. So I just, kudos to thinking about it. It's one thing to have the skills, but in the heat of the moment to act on it, particularly because otherwise you'd be stuck with another case of unexplained hypotension. I probably would have found those PEs because they've been high on the differential. But I mean, that way you were able to expedite and this patient's care and, probably improve it, although you'll never know because it's an anecdotal event, hopefully for you.
Hari, any questions about their utilization of POCUS here?
Thanks, Rahul. It's a very good case. This is the one which all the viewers and everybody should know. The most common use of POCUS is intraoperative hypotension. The good things in your poster I observed is you did a fast along with the POCUS of the heart, which is a good thing. Think of the other things as well. And I would also add lung ultrasound. It's really relevant, close to that one. So think of adding stuff along with, and saving the images is really the best option. As you said, if you don't save it, the clot may not be seen and they don't believe what you are, especially when you're doing POCUS. The other people need to believe what you did because they don't think you are an expert. So saving the images, and this is really a challenging case because the patient is in prone. So this is the most effective clinical use. Incorporate fast lung ultrasound along with the POCUS, save the images. That's my messages. Really well done.
Steve and Melissa, any last questions for Rahul before we move on to the next poster?
Rahul, I did have one question. I didn't know, based on what was put in the poster, whether you'd noticed any RV dysfunction or if you're able to measure like TAPSE in the apical 4 chamber.
No, we didn't really measure that. We didn't have time to go into that in depth. So yeah, we didn't look for any RV dysfunction or try to specifically evaluate for that.
Yeah, I mean, with the concern for the PE, that would have been really. I wonder if the cardiologist's echo also showed any change.
Yeah, they didn't really comment on it in their official report either. So, and maybe it was present while the thrombus was there and it just disappeared later.
Sorry, Steve, I cut you off.
No, I just wanted to say very quickly, one of the comments that you made is that you tried multiple views and some were better than others. And when you typically think about diagnosing a PE, it's the apical 4-chamber view or it's a parasternal short axis where you see that sort of end-systolic D shape. But this demonstrates that, if you don't see what you would expect to see with those typical views, keep looking, and eventually you can typically get some form of information from a focused cardiac ultrasound exam. So if you don't see something apically, go to parasternal. If that's not working, then go subcostal, but don't give up. You usually do get meaningful information eventually.
Excellent. Thank you so much, Rahul. I'm going to take you off the stream here, but appreciate so much for you coming and presenting your work.
Great. Thanks for having me. Appreciate it.
Thank you. Kwesi, I'm going to have you join in here. One of our people, I think, is running a few minutes late, so I'm going to skip and have you. Hey, how are you, Kwesi?
I'm great. Thanks so much for having me.
Yeah, let me jump to your poster here real quick. And this is poster number 1034 for those following along. And I'm about to put the link in the comments field and up on the screen. There you go. And I will try to keep up with zooming in, but if there's some place you want me to point directly at some point, let me know. But otherwise, go ahead and get started.
No problem. So it's a pleasure to represent my colleagues and our team. My name is Kwesi. I'm in Dalhousie University in Halifax, Nova Scotia, and I'm a staff anesthesiologist. It's my pleasure to present our study, which is the onset and incidence of diaphragmatic dysfunction after ultrasound-guided supraclavicular brachial plexus block, a prospective observational study. So what we did, essentially, was we were trying to examine the kinetics of diaphragm dysfunction as it happens relative to supraclavicular block. Now, a variety of different investigators have looked at the incidence before, but we were trying to examine, in particular, a bit of the kinetics. And to do that, we did something that hasn't been done before, which is we used the recent to regional anesthesia literature, the ABCDE technique, or the zone of apposition method for assessing diaphragmatic dysfunction. And this method has a few advantages over previous methods that have been used to investigate this. So as many of you know, there's been a variety of studies that have looked at diaphragmatic dysfunction related to brachial plexus blocks. In particular, several years ago, there was a dozen or so investigations of interscaling block with different volumes and up-down studies. And a lot of them used ultrasound. Most of them used the subcostal approach, so visualizing the diaphragm using either the liver or the spleen as a window to visualize the diaphragm moving down towards the ultrasound. Now, this has a couple of disadvantages. One is that most authors excluded left-sided surgeries when they did this, because the window to be able to visualize on the left-hand side through the spleen is often imperfect, and it can be difficult even on the right side, particularly in obese patients. Also, a lot of investigators used a comparative technique where they actually did a visualization before and looked at the movement and compared that movement to the visualization after, which is not what we did visualize before and after, but the measurements are actually independent. So our decision is made based on a single visualization. So instead of looking for the movement of the diaphragm, what we're looking for is the thickening of the diaphragm. All muscles, when they contract actively, they thicken. So that's what we're measuring. So diaphragmatic dysfunction is determined by having less than 20% thickening of the muscle visualized in the zone of apposition in the lateral chest, which is easy to do on either side in patients and regardless of their body habitus. So what we did, this was an observational study. We took 30 patients and we did supraclavicular block. We did a double injection technique where we put half of the local in the corner pocket and we put half of the local above the area that would be sort of superior trunk or the anterior posterior divisions of the superior trunk deep to the prevertebral fascia, and we put half the local there. And then we did diaphragm assessments at baseline, and then at 5 minutes up till 30 minutes, and then we did a post-operative scan. And what we found was that the kinetics were, that the mean for onset was about 15 minutes, which wasn't a huge surprise. The thing that was a huge surprise was, incidentally, the incidence that we found of diaphragmatic dysfunction was much higher than has been previously described, and was 80%. Most of these patients had onset of their diaphragmatic dysfunction within the first 30 minutes, with the exception of a single patient who actually was diagnosed in the postoperative period. We looked at breathlessness based on the Borg dyspnea scale, and very few patients had dyspnea. There was one patient who had reported significant dyspnea, 5 on 10 on the Borg dyspnea scale, which is severe dyspnea. But this patient had a BMI of 42, and their dyspnea didn't require any treatment, some reassurance, and it resolved. They didn't need any support, and they were discharged home without any incidents. There were 4 other patients that had dyspnea, one that had 1 out of 10, and then 3 patients that had 0.5 out of 10 of dyspnea, so very mild dyspnea. So in the end, what we saw was one that potentially diaphragmatic dysfunction after supraclavicular block is potentially more common than we thought it was. And also that the onset is largely quite quick, but can be occasionally delayed. So it's something that you don't want to miss, and it makes us question the relative advantages of supraclavicular block for example, shoulder surgery, when an interscalene block might be used if the incidence is that high. The caveat I will say that a lot of other studies that have looked at supraclavicular technique have not specifically identified exactly what technique that they used when they did a supraclavicular block, and have left it up to whoever was conducting the block. We didn't. We controlled for that, and that may have had impact on the incidence.
Excellent. Thank you,
I'm
Kwesi.
happy to take any questions.
Yeah, I'm going to start with Hari, because Hari, when we talked about a few posters last week with questions about diaphragmatic involvement from different interscalene supraclavicular blocks, you had a lot of questions in the comments and stuff like that. So I thought you'd be a good person to start and asking about this technique.
Thanks, Kwesi. I like this technique. It's easy to get the acoustic windows. So based on your experience, because you teach and you do a lot, which of the following, like the subcostal or the diaphragmatic movement, measuring the space, or this one, which has the highest sensitivity and specificity, which do you think we need to propose for people if they are looking for the hemidiaphragmatic paresis?
So both have been both are validated, and there's no question that the ABCDE technique is dramatically easier to do. It's independent of body habitus. The measurements that you take don't require a preoperative measurement, so you don't need to know the pre-status. You can do a single scan. So if you're in a clinical situation where you're trying to assess diaphragmatic dysfunction, as I said before, you don't need to have a previous assessment to be able to do that. You can just look for the thickening. And because you can do it on both sides, because it's independent of body habitus, to me, it makes the technique wildly better. It's easy to learn. I teach medical students and residents to do this technique in a 15-minute session, and they can acquire them very quickly.
Melissa, any questions for Kwesi on this?
I was just wondering, and I think a few of the people in the comments section have mentioned the higher volume of 30 mLs of ropivacaine. Is this standard practice, or was this something just decided upon for this study?
No, I think it's a pretty typical volume, somewhere between, 25 and 30 cc's in the supraclavicular space. I don't think is a particularly high volume. Could you do a lower volume technique? Absolutely, it's possible. I think as your volume gets lower, then of course your failure rate's going to increase. In particular, in this study, we didn't leave it up to the individual practitioners. So normally clinically, when I'm doing a block, I don't really have a fixed volume that I'm trying to give. I really administer whatever local I think is required to be able to accomplish and sort of fill up the space. And you know what? Maybe that'll be 15 mils, and maybe it'll be 30 mils, depending on what I see. But we didn't leave that up to because we wanted to control for that. We didn't leave it up to the practitioner, so we had a fixed volume, and that might be a limitation.
We had an interesting conversation last week on one of the posters presented, and they showed that they noticed diaphragm dysfunction down to 5 mLs. So, trying to cut the volume down may not help us as much as we think we're saving the patient's diaphragmatic function. That at any volume, you're pretty much guaranteed to get a high rate of diaphragmatic dysfunction anyway. And so the conversations about 10 or 12 mLs for the supraclavicular block may not be as sparing as we would like to think it is. Jan, last question. Any question for Kwesi here? Oh, then Steve, we'll do a quick one there.
No, I just was curious if you differentiated between diaphragmatic dysfunction and diaphragmatic paresis, because I think that particularly when we did our superior trunk block study comparing that to interscalene block, we saw that there was some dysfunction, but not always paresis, and I think that can make a big difference clinically for certain patients.
So that's a great question. Using this method, paresis and dysfunction has not been defined. So usually when you're defining paresis and complete paralysis and sort of a lot of studies refer to as sort of partial paralysis, they look for paradoxical movement instead of having sort of normal dropping of the diaphragm, as evidence of complete paresis. Of course, with this technique, we're not looking at movement, we're looking at thickening. So, normally when you have a normal diaphragm, often you can see that the thickness is it's almost doubles its thickness when it's normal. But we don't have a definition. We use a sort of a firm definition, which was 20%. Anything less than 20% thickening. So we didn't have it. I'm not sure what the other definition we would use.
Jan, you have a quick question or comment?
No, that was going to be my question too, right? Because this dysfunction 80%, is a lot was a lot higher than what we were always hoping for, and particularly in light of the HSS study that Stephen was involved with. It was sort of like surprising, which works well to confirm my own bias towards the superior truncal block. But we need to, in the interest of science, we need to work on like a definition and also validation of the ABCDE technique versus the other standard methods.
Just as far as the diaphragmatic paresis element, sorry to drag this on, but definitely with the paradoxical movement with the subcostal sort of sniff test, that's one way to confirm essentially paresis versus dysfunction. But I'm pretty sure Ben Su did publish something with the ABCDE technique demonstrating that maybe with the sniff there is some sort of movement of the diaphragm that can suggest paresis versus dysfunction. I don't know the details, but something for future discussion.
I think he's talked about it, but I don't think there's been any validation of it. I think it's been postulated, but there's been no validation of it. So I think it's certainly interesting to look at, but I still think that the big advantage of this is we can get a clear measurement in all patients, and you can argue about whether or not it's complete paresis or whether it's partial, but it's significant. So it's easy to do and reliable regardless of body habitus and regardless of laterality. So I think that's a huge advantage. At least in my practice, I use it routinely.
Thank you, Kwesi. I'm so glad you were able to join us to present this work.
Thank you.
I really appreciate it. I'm gonna.
Oh, thanks so much for having us.
Yeah, I'm gonna get the next author on here, and hope to see you again in person soon. I'm gonna pull Julie Holroyd up in here. Hey, Julie, how are you?
Hey, good. How are you?
Let me get your poster up. This is poster 981 for those of you following along, and I'm gonna put the link up here and get it up on the screen. So this is aggressive fluid resuscitation and increased capillary leakage leads to false positive FAST. So I will let you take this away, Julie. Go for it.
Awesome. Thanks so much. So hi, my name is Julie Holroyd. I'm a CA2 resident at the University of Florida, and I'll be presenting the case of a patient with a false positive FAST exam for intra-abdominal bleeding, where further workup with a CT scan did not demonstrate active bleeding. So this was a 39-year-old female who required emergent hysterectomy after delayed uterine atony following an uncomplicated vaginal delivery. And point-of-care ultrasound was available and used in this case to help determine the cause of hemodynamic instability. So this patient lost 3.5 liters of blood and was resuscitated with 2 liters of crystalloid, 1 liter of albumin, and multiple blood products. And she was hemodynamically stable on emergence. So she went to the PACU postoperatively, and anesthesia acute pain service was called to place continuous tap blocks to help with pain control. But during the placement, she became hypotensive and tachycardic with downtrending hematocrit and platelets. And since ultrasound was available, they had just used it for the tap blocks. They went ahead and did a TTE and a FAST exam. The TTE showed hypovolemia and the FAST was positive for free fluid. So at this point, the surgical team was notified for possible re-exploration, but prior to going back to the operating room, they went ahead and got a CT scan, which showed hemoperitoneum without active bleeding. So we can see on the picture on the bottom right, the blood surrounding the patient's liver there. So she was actually diagnosed with DIC and resuscitated with additional blood products, and she did start to improve, and serial fast exams remained stable as well. So what's interesting about this case is that the positive fast exam could have led to multiple different treatment options, given in the context of the hemodynamic instability and the downtrending lab values. This could have necessitated a return to the operating room for surgical correction of bleeding. Or this could have represented a normal postoperative finding after major abdominal surgery with large volume fluid resuscitation. So, ultrasound's very quick, useful tool for anesthesiologists, has excellent specificity up to 99%, which it's important to remember that this is studied in trauma bay patients. So when a patient comes into the trauma bay and has a positive FAST, they just bypass the CT scanner and go straight to the operating room. So this was a different sort of case scenario, not in a trauma patient. But, this is also not without its limitations. The FAST exam has poor sensitivity, variable positive predictive value, also things like the sonographer experience, the amount of fluid needed to be present for detection, the ability to differentiate between blood versus other fluids, and even normal anatomy can result in false positives. So if we hadn't taken, the full picture, the full clinical setting into account and did not get the CT scan, the positive FAST in this case could have been assumed to represent active bleeding, meaning she would have had to go back to the OR unnecessarily. So the aggressive fluid resuscitation performed for this emergent hysterectomy combined with the increased capillary leakage from the DIC is what's suspected to have led to this false positive FAST exam. So it likely represented extravagated fluid and old blood in her abdomen.
Excellent, Julie. That was a great presentation. Melissa, I'm going to start with you. Any questions for Julie?
No, Julie, that's really interesting case presentation you provided. I think that many of us, as when we are teaching fast, our expectation is that if you see something that's probably the reason why you should take someone to an operative setting or to act on. And I really am, it's interesting to see that you've made that differentiation between active bleeding, extravasation in a patient with, high potential for IC in the setting of uterine atony, but also using ultrasound then as an adjunct in combination with the clinical findings and suspected diagnosis is really the important take-home point, just as you've provided.
Right. And the only other thing I guess we could have done was the lung sliding for maybe like pneumothorax if that was suspected, like you guys had talked about on the presentation before last. So that would have been a good thing to do in addition to the TTE and the FAST exam.
Hari, any questions for Julie?
Julie, that was good. That's a good case. I like your poster. You mentioned all the clinical good points in bold black, which is really good. Expertise in the clinical context are really important when we're dealing this, and knowing the sensitivity and specificity of a particular test is really valuable because FAST has low sensitivity. So that's another thing. The last question I have is, did your FAST findings correlate with the CT findings, or did you have anything different?
Nope, they did correlate. So that's what we saw. We saw just fluid in the abdomen and weren't sure at that point if it was blood versus other fluid. And they went ahead and got the CT scan before going to the OR, and it did show that there was blood around the patient's liver, but it wasn't an active bleed. They're able to say how much is bleeding if there is active bleeding based on the CT. The radiologist, when they had talked to them, and they said, no, this does not look like it's active bleeding.
And
So
I liked your concept of serial exams. That's what we need to do. And you did everything like a textbook.
Right. Yes. Yeah. And they remain stable. So all of her symptoms were managed conservatively.
Excellent.
Mm-hmm.
Jan, any questions for Julie?
Yeah, no. I mean, Harry, like the serial part in conjunction with everything. So it's fantastic, that's sort of like using it, if you can worry about, the lung sliding, then that's good, because everything else, you're in the 95th percentile. So now you worry about the other sort of like, what else could I have done? But you did everything right. The serial opportunity, like I mean, it's just so hard to go back to the scanner,
Right.
So this you just do at the bedside.
Yeah, exactly. The sensitivity is low, 60 to 80% alone, but when you do the serial exams, it does increase the sensitivity. So we definitely saw that. Yeah.
Steve?
Sorry, I'll be quick. No, I think this is a really exciting clinical case, because it demonstrates what happens when you take point-of-care ultrasound tools that were initially designed for one clinical setting and you move them into another clinical setting. So fast exam is a trauma tool initially for patients who you expect to show up in the ER bay, and if there's blood, you treat it because it's probably from whatever penetrating trauma or blunt trauma they had. But here we are in the perioperative setting, where we're seeing that there may be fluid in the abdomen for other reasons. So again, that's where getting a baseline in the PACU and following serial exams comes into play, and the notion that we treat we treat patients and not ultrasound images, right? So you look at the clinical context, you look at how the patient's clinical state is evolving, and you use that ultrasound to guide management. You don't use the imaging as the definitive treatment plan. So I think this was a great case.
Excellent. Thank you so much, Julie, for joining us. I really appreciate your time, and I'm glad you were able to share your work. Thank you.
Thank you. Thank you very much.
So our next poster, we've got two people on. So Steve, because you're going to be presenting the one after that, I'm going to hide you for just a few minutes here. You're not gone, just hidden. And I'm going to get Sagar and Cornell on. Hey, how are you guys? Thanks for waiting. I know I saw you guys waiting in the wings this whole time. Cornell, your mic is muted, by the way.
Thank you. I think it's good now.
Yeah, there we go.
All right. Thank you for having us, guys.
Yeah, so this is poster 1207, and I'm putting the link for people into the notes here in the comments. And let's get your poster up. And I don't know how you guys want to coordinate. If one of you wants to present one part of it and the other, go for it. But whoever's not speaking, mute your mic so that it's a little bit easier for people to hear.
Perfect. I think Corey's going to start with the presentation, and then I'll take over halfway. So I'll mute first, and Corey will get started.
Right. So my name's Cornell Conca. I'm one of the anesthesia fellows at the St. Francis Medical Center in Hartford, Connecticut. And I'll be starting us off here. Our study was a retrospective analysis of the incidence of cardiac complications following total joint replacement surgery. We focused in on the year 2018. Preventing these complications after total joint surgery, or any surgery really, is of significant importance to us, because they often lead to poor outcomes postoperatively and can place a heavy burden on healthcare resources. We as anesthesiologists play a pivotal role in determining the risk of the likelihood of these complications by assessing and screening patients preoperatively, and hopefully only allowing patients who are appropriate to actually proceed to have their surgery. However, determining this preoperative risk can be specifically challenging in the total joint replacement population, because these patients often have debilitating pain, and it's assessing their functional capacity can be limited for that reason. So oftentimes we rely on our colleagues in cardiology to help determine what their preoperative risk is using various techniques. But still, it comes down to us in the immediate sense to determine, looking at the patient, oftentimes they look different in person than they do on paper, and making a judgment of whether or not they should proceed with surgery. And I think that in the context of point of care ultrasound, our study may have highlighted a patient population that could benefit from a bedside echocardiogram prior to their procedure, depending on what their workup was. Specifically, the objective of this study was to determine preoperative screening, whether or not it was accurately predicted the risk of the cardiac complications after lower extremity joint replacement surgery, and took a look at the timing of these cardiac events as we head into an era of more same-day total joint surgery. So our study got underway after our IRB approved the methods. We looked at the Connecticut Joint Replacement Institute's database and it identified patients using ICD-10 discharge codes, looking to see who within 90 days following their surgery, if anyone had any angina, myocardial infarctions, congestive heart failure exacerbations, arrhythmias, or syncope. Once they were identified, Dr. Sutaria and I looked at the patients that were identified to sort of further determine what their preoperative workup had been and whether or not an appropriate evaluation had been performed prior to their surgery. And then I'll just present a little bit of the data here. If you look, we identified, the database identified 29 patients out of a little bit over 3,000 surgeries over the course of 2018 that had developed some form of cardiac event. The majority, in table 1, you can see the majority of the patients were of an older population, the average age being 75. And you can see, I believe, in the next table, the most common the most common cardiac event were CHF exacerbations. And with that, I'll leave it to you, Sagar.
Hello, everyone. Sagar Sutaria, also a regional acute pain fellow at St. Francis Medical Center. Thank you, Dr. Kanka, for getting started there. So as we look at the data here, a couple things that really stick out. First and foremost, 14 out of our 29 patients, the inciting postoperative cardiac event happened within 4 days. So that's pretty significant in that if we're trying to put this in the context of doing the 23-hour stays and the same-day joints, I think it's important to know that majority of these patients are having these complications in the immediate kind of post-operative setting, and 4 out of these 29 had them actually either intraoperatively or in the PACU post-op day 0. So relatively soon after the surgery. We did find that of all the data, we found that tachyarrhythmias and heart failure, like Corey had mentioned, were the most 2 common. And again, taking this a step further to kind of put into context of point of care ultrasound, this is where we can use point of care ultrasound to further either work up these patients post-operatively, in the meantime, while we're waiting for cardiology or, medicine colleagues to see these patients, we could definitely utilize point of care ultrasound to assess volume status, assess global cardiac function, look for pneumothorax, look for possible PEs, all those type of things that could lead these patients to have some of these adverse cardiac events. Furthermore, we did see about 38% of our patients, 11 out of the 29, were identified to be minimal to low risk, and then they did have these postoperative cardiac complications, which is concerning. Granted, we only looked at 1-year data, and this is kind of a smaller study, part of a bigger series of data collection that we're looking to do. We have data for 6 or 7 years, so hopefully we can kind of keep looking at that data. But 38% is still a relatively high number of patients who developed cardiac complications, even though they were deemed low risk. And the overarching kind of takeaway point of this is, as we look to proceed to these more and more of these same-day joints, or doing these same-day joints in freestanding ambulatory surgery centers, perhaps we should be looking to do a little bit more of a stricter risk stratification process, and kind of one of the tools we can incorporate into that process, as Corey mentioned, was using point-of-care ultrasound, despite the patients may or may not have had preoperative echocardiograms or preoperative assessments. They come to our pre-op bay in the morning. It's really up to the anesthesiologist to determine whether or not this patient is a suitable candidate for surgery. And often, like Corey mentioned, patients look different on paper than they do in person. So I think that's where we could really tie in that point-of-care ultrasound, and really think we need to really make a more stricter guidelines as to who we approve for same-day joint replacement surgeries.
Excellent. Thank you. Jan, I'm going to start with you with questions about the use of point-of-care ultrasound in this these cardiac concerns.
Yeah, no, I think it's important, very important always to get a baseline. So I think, to get like also the 11 people that are unexpected, if you think about that, it's like 11 out of 3,000, right? It's not 11 out, so there is also a percent, but it's certainly a high yield, like if somebody has a history of CHF, so a preoperative echo is what I do, because it affects induction, a lot of things. And, probably people with CHF are probably not the best candidate for those outpatient joints to begin with. But I like the systematic approach. And I know that Sanjay has been at one of our ASRA POCUS courses. So we're hoping to be able to, once all of this returns to a more sociable way of life, that we see both of you or many of some people online at these. But I think it's so powerful. I mean, I know in Boston, the pediatric orthopedists do on every athlete only one view, because they're mainly concerned about HOCM and LUS function. But it's such an important trigger, and that's where a lot of concern always comes from, is that we're going to take our patients away. Like in that couple of posters back when they're presenting hypotension, these are patients that are not going to be followed by a regional anesthesiologist. They're going to be followed by a cardiologist. So I think it just improves patient care. But I really like the systematic approach you guys are taking how often, what is this stock, what is the high yield intervention. I thought that was fantastic.
Melissa, you want to follow up?
Well, one of the things that got me thinking is, number one, the data is quite alarming that this many people had cardiac events after total joint arthroplasty. But also, I think it just pushes us to really embrace the technology, the ultrasound technology that's portable, because that can go into these outpatient surgery centers that are looking at same-day joint replacement, but also or 24-hour short stays, and having that readily available.
Yeah, I think that, not having all those cardiology people ready like we are at the big academic centers is a luxury not everybody has, whether it's outpatient surgery or even some hospitals inpatient surgery. They're not going to have somebody readily available to jump on that case and help you in a moment's notice. And the more skills we have to kind of at least do cursory assessments, we can triage people better. Hari, you want to follow up with a question?
You said all the cases from lower extremity. Just an interesting thing. Is there any particular surgery, revision knees, revision hips, which group had the highest complications?
It was total hip replacements had the highest rate of complications. I don't think that we identified any particular reason. I don't think in our demographics there were any major differences in their comorbidities leading into the surgeries. So I'm not really sure why it was total hips.
Recently, Stavros published a paper, I think, saying that outpatient joints are having more morbidity and mortality. So that's the reason we pulled your study, which is to look at the retrospective data. It's good. That's where we need to find and do something and help with the POCUS, especially as Melissa was telling in the outpatient centers. Thank you.
Like I mentioned, this is we have tons more data, and this is just kind of a snapshot of it. So hopefully we'll be able to incorporate all the other years of data, thousands and thousands of cases, and kind of see if these trends do stick stayed true amongst all those years. So.
Well, thank you guys. Steve, I'm going to cut you off here for the sake of time, so I want you to present the next poster. Sagar and Cornell, thank you so much for participating. I'm going to kick you guys off.
Thank you for having us, guys.
All right, let me take you guys off. We'll get Jan back up on here. And we're going to do, Steve, you're going to present a poster too before we start talking about the COVID POCUS stuff. This is poster number 1199. And I'm putting the link in the comments. And we'll pop it up on the screen. Titled Anterior Quadratus Lumborum Block Does Not Provide Superior Pain Control Following Hip Arthroscopy. Take it away, Steve.
Okay, so just before I get started, I want to make sure I thank all my co-collaborators who worked very hard to collect data. It was a somewhat challenging study to coordinate with all the different elements. I want to particularly thank our first author, Audrey Singh, our research assistant, who was running around like crazy for the last year and a half trying to get this done. So even though this is really an ultrasound-guided regional anesthesia study, it was inspired by a POCUS study that we performed at our institution that was published in ANA back in 2017, where we used the FAST exam as a means to evaluate how often we would see intra-abdominal fluid extravasation happen in patients who are receiving hip arthroscopy. And so historically, intra-abdominal fluid extravasation, which is fluid tracking from the hip joint into the peritoneum during hip arthroscopy, based on retrospective data, happened about 0.14% of the time. And our study, we saw it happen 14% of the time. So it was a 100-fold increase in terms of how often we would see fluid extravasate from the hip into the peritoneum, and we found that those patients had greater change in their pain score. So they were having a less comfortable experience post-operatively. So when we published this data, we received a letter to the editor, and the recommendation based on the letter editor was perhaps we should consider doing quadratus lumborum blocks on these patients, as they've seen some benefit for certain hip surgeries and it's been effective for abdominal and pelvic surgery, and perhaps that would help treat some of the visceral symptoms that you might see with fluid extravasation into the peritoneum. And so in addition to that, we've seen some retrospective studies that might suggest that this is an effective block for hip arthroscopy. So that inspired us to put together this study. And so what we did was we enrolled 96 patients that were randomized to either receive a standard anesthetic and multimodal analgesia, which involved the spinal and intraoperative IV acetaminophen and ketorolac, versus receiving a transmuscular or QL3 or anterior, whatever you want to call it, based on the nomenclature, but a quadratus lumborum block where you're injecting the local between the quadratus lumborum muscle and the psoas muscle. So we injected 30 cc's of hapercent bupivacaine, and we did add preservative-free 2 milligrams of preservative-free dexamethasone. And then we took a look at primarily pain scores at rest and movement at 30 minutes, so preoperatively 30 minutes, 1 hour, 2 hours, 3 hours, and 24 hours upon arrival in the recovery room. And if you take a look at table 1, essentially what it demonstrates is that there was no major significant difference. We saw that there was a statistically significant difference for NRS pain score at rest 30 minutes after arrival at the PACU. It's arguable whether or not one point really is clinically significant, but it was statistically significant. All the other times there was no significant difference. There was also no difference in terms of 24-hour opioids, PACU antiemetics, and patient satisfaction. What was helpful, and I thought was a meaningful finding, was that we didn't notice any difference in quadricep strength. So despite using a fairly robust dose of 0.5% bupivacaine, it was a motor sparing block. This demonstrates essentially that as a preemptive block on healthy patients who at baseline didn't have a lot of pain, that it didn't really provide any significant benefit over standard multimodal analgesia. Now, what the point of care element of this is that we also performed a fast exam on all these patients preoperatively and postoperatively, and we looked for the incidence of intra-abdominal fluid extravasation. And as you can see, it was even higher than what we saw before. In the 20% range, while before we saw it at about 14%. And I think that possibly may be due to the fact that we're just getting better detecting fluid now than we were before. We're also using slightly different equipment. One of the things that we did look at, although we weren't necessarily powered to look at this, was whether or not there was a difference in between the groups of whether or not they received a QL, quadratus lumborum block, or control if intra-abdominal fluid extravasation was present, and we did not see a difference in terms of their pain scores either. So the quadratus lumborum block did not provide a benefit for the patients that had intra-abdominal fluid extravasation.
I'm still muted. Hang on. Can you guys hear me?
Yeah.
Okay. I don't know why my video is frozen, but we'll get that back on. I'll get that sorted out in a second. So I'm going to pass on a question from Nabil. He said, one, did you guys report on intraoperative opioids? And two, was what was the exact nature of the arthroscopy? Was there bony work or just labrum repair?
So there was a variety of cases that were done from just standard sort of labral repair and femoral osteotomy to there were some psoas release. As was the case in our previous study, there was no difference in terms of intra-abdominal fluid extravasation. We also didn't really see significant difference in terms of overall pain between those groups. With 96 patients, it's really difficult to differentiate between surgical procedure and pain score, and particularly with looking at a complication like intra-abdominal fluid extravasation. But we didn't really see a big difference in terms of the actual operation that was performed. We did look at intraoperative opioids. All patients received a small dose of fentanyl at the start of the case. And then for patients that were having pain or appeared to have pain at the end of the case, they were able to receive up to 1 milligram of dilaudid, and that was taken into consideration.
Jan, you have a question for Steve?
Yeah, no, I mean, of course we're sad that, so there was like no helpful findings in terms of.
It's helpful for things to be negative sometimes.
Yeah.
Well, yes. I mean, and I think it's really important. I think it's great, but it's like the QL block did not help. Did you find a difference? But I think it sounds like you did for intraoperative use of opioids. And did you find? So what is like the next step? I think ultimately it's sort of like the hip is complex, and do we have two? Ultimately, I think there's a question, we probably agree on that, as we agree on a lot, is do we have two different pain drivers, the hip and the abdominal pain in hip arthroscopies?
There wasn't there wasn't a statistically significant difference in terms of intraoperative opioid use between the two groups. Now, I can tell you anecdotally, I don't think there was much of a difference in terms of, sometimes you'll see if patients get the QL block, they can last a little bit longer than someone who just has a standard spinal. I don't think that happened significantly more. I do think one of the issues with looking at the QL block for treating intra-abdominal fluid extravasation is that the QL block is a unilateral block. And if fluid extravasates into the peritoneum, then that is going to irritate the peritoneum bilaterally. So you really have to do sort of a bilateral block in order to really make sure that you're covering that as a source of the pain. So I will also say anecdotally, although we haven't studied it explicitly, that this is a fairly effective block as a rescue block. So if your pain is 12 out of 10 and you get it down to a 6 or a 7, then it looks pretty effective. But if you do it preemptively on someone who's at low pain score at baseline and postoperatively they just had surgery and hip scopes hurt, then it doesn't really look like it's that effective.
Hari, any questions for Steve on this one? I don't know where you are on the QL argument about whether it's covering visceral pain or not, but
No, I was just about to ask the same question because Steve presented a case report, QL is working, and now his results came back. So that's what I wanted to ask.
So do you think
So,
this
Harry.
QL works, huh, Steve?
Sorry.
Do you think the QL works at all?
I've used it as a I've used it as a rescue block, and it's been effective. It doesn't make the pain go to zero. It's not like doing a brachial plexus block, and as Jan mentioned, the innervation to the hip is complicated. And then you're taking into consideration that there might be a peritoneal element to it as well. So it's definitely no magic bullet.
Yeah. Melissa, any thoughts before we wrap up this last poster?
I know you didn't remark on it, Stephen, but was there any concerns about intraoperative hypotension or hemodynamic instability for those that received the block versus those that were on the standard multimodal?
We did not see that, and we're doing a relatively low lumbar block, so we didn't see that there was any significant threat to spread to this notion of the potential lumbar paravertebral space and hemodynamic changes. Yeah, we didn't see that with 30 cc's unilaterally. No.
So we're going to do a quick little shift here. Normally I do the introduction with saying that we're not going to talk about COVID-19 during this session and give everybody a break from it. I didn't do that today because we actually are going to talk a little bit about COVID-19. For the authors that presented their poster that are still sitting in our deck, you guys are welcome to stay, but if you have other things to do too, I completely understand. You're welcome to walk away as well, or continue watching separately online. Either way is fine with me. Harry, are you starting or is Steve starting with this present? Who's starting with this one?
I think, am I starting, Harry? Right, yeah.
Yeah, his mic was muted. I couldn't tell what he was saying.
Yes.
Okay, so this one, we're just talking a little bit about the use of point of care ultrasound. There's been a lot of talk on social media and some other information that's been published out there on the value of point of care ultrasound in the assessment of patients with COVID-19. So we thought this would be a good opportunity with these very, very smart people who know about point of care ultrasound, which I am not one of them, to talk a little bit about some of the stuff that could be useful if you're dealing with patients with this illness. So Steve, you want to take it away, and we'll get, you just tell me when to advance and we can move through slides.
Sure. So I just want to think it's helpful for us to discuss this topic since obviously it's very relevant and something that I think a lot of us will be thinking about and potentially dealing with. If we haven't so already, as our sort of adjunct roles as ICU physicians during this COVID crisis. But when it comes to the use of POCUS for COVID-19, it actually was highlighted fairly early on in the literature. There was a publication that came out of intensive care medicine. If you're in the ASRA POCUS SIG, we highlighted it in our last newsletter, but the Chinese critical care ultrasound study group published the role of lung ultrasound in COVID-19 and specifically sort of the most common findings with some of the patients that had COVID-19. And that was published on March 12th. It's been cited almost 60 times since then. So it's clear that there's a lot of publications, a lot of interest in the role of POCUS for a variety of reasons. And there are also a lot of great online resources that are available. So this is going to be sort of a snapshot. We're going to keep it relatively simple. I did find a very helpful online resource. It was very succinct through medcram.com. They had a YouTube video with Dr. Joshua Jacquet, and he really did a great job of deep diving into the use of lung ultrasound for COVID-19. So I wanted to put that out there if you wanted a good 40-minute synopsis of all the things to look for. So we'll advance to the next slide. So as I mentioned, there's been a lot of publications that have come out regarding POCUS and COVID-19, and one of the most recent ones was published by the American Society of Echocardiography, the ASE. And so they highlighted multiple different uses for point of care for COVID, not just cardiac, which you think sort of would be in their wheelhouse, but also the use for lung ultrasound and for vascular. And so I'm going to go over some of the findings for lung ultrasound ultrasound, and then Hari is going to touch on cardiac and vascular. And so this is a nice summary chart, and you know, I think the main thing that we see here is that when you're performing a lung ultrasound exam, as you can see under sort of structure and lung, they mention this 12-point exam. Now, really what they mean by that is you need to do a comprehensive lung exam, because what you're going to see in someone who has a viral pneumonia instead of someone who may have CHF or ARDS is that it's often a focal or multifocal. So you're going to see it in very specific locations, and it's not a diffuse presentation. So you really do need to scan sort of broadly, and they often describe doing this sweeping sort of lawnmower type scanning where you start from one side and work your way back and forth to make sure that you evaluate the full lung, and you're assessing the pleura, and you're looking for things like A lines and B lines, with B lines being sort of the most common indicator that you have an interstitial process going on, and that might indicate a pneumonia. Now, when you see things like consolidations, then that causes there to be this irregularity in the pleura, this pleural thickening, and often you see these sort of hypoechoic signs of the regular pleura. And so that's where you can use it to sort of go one step further from just B lines, like there's an interstitial process, to consolidations. And then finally, pleural effusions are something that you can evaluate for as well, although they're based on most of the data out there, it's fairly uncommon to see a large pleural effusion. You may see a small effusion at either the base of the lungs, or you may see it where you see these consolidations. So we'll move on to the next slide. And so again, we see here B lines are our main thing that we're going to be evaluating. And so focal versus diffuse, that's one way to help you differentiate when a patient comes in the door. Nowadays, if a patient comes in and has pulmonary symptoms, I think COVID-19 is at the very top of our differential diagnosis, but it is possible that they may have something else like congestive heart failure and that's the source of their respiratory distress. And so we want to keep in mind that the difference between someone who has a CHF type picture where you see diffuse B lines versus a viral type pneumonia is it's going to be focal or multifocal. So you see these sort of consolidations in certain areas or multiple different areas. These small subpleural consolidations, that's where you'll see the lung thickening, the pleural thickening, in addition to B lines, and these irregularities where you see sort of the pleural line have these hypoechoic sort of small fluid collections in between the pleura. That usually suggests that you have a consolidation. As we move into the more worrisome territory, where you see hepatitization of the lung, where you have significant consolidations, AR bronchograms, that's where the patients move into the potential ICU ARDS type of setting. So generally speaking, you're looking for B lines. They're not going to be diffuse. And they're most commonly at the base of the lungs. So move on to the next one. And so this is a nice summary from anesthesia. Again, looking at where you see a fully aerated sort of happy lung, where you see A lines that are prominent, and you're not seeing any B lines. And as you move to more of an interstitial process from the viral pneumonia, you see a prevalence of these B lines. You see here the pleura is sort of brighter and thickened, which suggests irritation of the pleura. As you move into a consolidation type of picture, then again the lung starts to look like the liver. That's the hepatitization, and you may see effusion. So why is this a benefit to us? Well, I think there are a variety of reasons why lung ultrasound is helpful if you're evaluating a COVID patient. Obviously, unless we're working in the emergency room, we're not often on the front lines, but it does help us triage when it comes to assessing which patients may be at high risk for moving in the wrong direction and decompensating versus ones that may be able to be stable at home or be stable on a regular floor and not need to go to an ICU. And so the Butterfly IQ actually put out through Mike Stone a recommendations on how to potentially use lung ultrasound to triage patients. So for example, if you have a patient who has no supplementary O2 requirements and has just A lines, as you would see on the left upper left hand of the screen, then that's someone who most likely is low risk for acute decompensation and should probably quarantine at home. Alternatively, if you're not requiring oxygen and you have some focal B lines, again, that also may be someone who may be able to stay at home. Once you require supplemental oxygen and you start moving into the category of seeing these diffuse B lines, coalescence of the B lines, which means that you're not seeing any darkness in between it. Essentially, the entire lung looks like a waterfall, as it's been described, or you're seeing pleural thickening, significant pleural thickening, then that may be the obvious indication that a patient needs to be hospitalized. And once you move into the consolidation territory, that means you're approaching more of an ARDS phenomenon, and you might want to consider ICU status. So this can help guide ICU decision making. It can help sort of determine which patients really need to be admitted to the hospital or stay home. It allows you to risk stratify which patients are at low or high risk for potentially advancing in terms of their disease and requiring further intervention. One of the things that's interesting is that obviously there are resource limitations in terms of getting testing. And so if you're in a situation where you're unable to get tested, this could be a way to potentially confirm COVID-19. I'm going to tell you, I had it. I had COVID-19 a few weeks ago, and I had some fevers and some body aches, a little bit of a cough for the first few days, and I scanned my lungs pretty routinely, and they looked okay. And then day 5, I saw B lines and pleural thickening and a small pleural effusion, and I wasn't able to get tested because in New York it's just impossible to get tested. But it was very clear to me that I had it. It was a little scary, but but I'm fine now. And those have all gone back to their baseline, which is I have lots of happy A lines and no effusion anymore. And so not only can it help you sort of potentially diagnose the disease when you don't have the resources to get the PCR testing done, but it allows you to follow the progression of the disease and aid management in an ICU for lung recruitment maneuvers or assessing whether or not prone positioning is helping in terms of decreasing these consolidations and potentially even aid in prognosis. And that's where some of the cardiac ultrasound scanning also comes into play when you take the full picture into consideration. In the end, it's always a matter of risk versus benefit when it comes to the use of ultrasound or any sort of clinical tool. I would say that the risk of this is obviously we're carrying a device into the room. We're physically going into the room that we could, if it's not adequately cleaned and decontaminated, could potentially contaminate other patients. So you want to use very rigorous, donning and doffing and decontamination of your equipment. That's where these smaller ultrasound, handheld ultrasounds come into play because they're much easier to move around and can be cleaned a lot more, I say, effectively and probably efficiently than the larger machines. The benefit, it's cheap, it's fast. We can't get routine CT scans on these patients, so we're it's definitely a benefit for us to be able to do this quickly to again look at progression of disease, and finally I think the benefit is that it is very accurate. In many ways, lung ultrasound is more accurate than your chest X-ray or even your CT scan in terms of showing significant disease. So that is that is my summary of lung ultrasound for COVID. It's, again, very broad, but there are a lot of other great resources out there that I highly recommend. Again, I'm going to highlight medcram.com. Their video I found very helpful.
Steve, I had no idea that you had COVID-19. I've been seeing a lot of other stories of people kind of who have point of care ultrasound skills assessing themselves during the course of their illness online. I didn't realize you had it. I'm glad you're feeling better.
Yeah. It's nice to have an ultrasound at home.
Yeah, something weird about the fact that you can get an ultrasound, but you can't get a test. I'm still having a cognitive dissonance with that, but we'll leave that where it is. Hari, I'm guessing you're on the next slide here, so why don't you take it away?
Thank you, Stephen. I will be covering the cardiac and the vascular part. So this is another important area we need to look at along with the lungs. So basically the cardiac POCUS is no different what you routinely do in a COVID patient. You just do the same stuff, but you think of more common things, more common in the COVID population. So look at the LV, look at the RV, looking at the pericardium. These are the three most important things, and a little bit about the valves. So the common entities that are encountered in these patients are myocarditis and looking for the global LV function. That's the most common reported incidences, highest incidence in these COVID patients is myocarditis. And they're also prone for thrombotic events. So they are developing these acute coronary syndromes. So they named it as a fancy name called corona syndromes. And looking at failures, cardiomyopathies, and as they looking as an entity of POCUS, see what you want, quick scan, come out. And in the vascular part, again, look at the IVC, and I added a VEXA scan. It is very advanced to the ICU, not for routine general population, to look at the volume status, looking at the IVC, portal vein, renal vein, and other stuff. And the last, as I said, because of the thrombotic events, we need to look at the veins, lower extremity veins, to rule out DVT in patients who are chronically ventilated or in the ICU. These are the three entities we need to cover. Next slide, Raj. So as I said, it's no different from the normal thing. So I usually use the basic FATE views. The 4 views, pretty much very reasonable to do a POCUS in a COVID-19 patient. So basically, then we should question ourselves, why are we doing? What are the reasons we need to do? So the main aim is to detect any pre-existing cardiovascular disease, or to see if there is any worsening of the previous existing disease or anything new that is due to the COVID-19, and monitor the changes in the cardiac function. As I said, specifically look for myocarditis, global or LV systolic function, looking for pericardial effusion, looking for the RV. That's the most common or important thing that when the patients are being ventilated or hypoxia, looking into the RV, looking at the pulmonary pressures, pulmonary hypertension, and maybe into the PE aspects as well. So those are the things to look, and specifically because of the corona syndrome, looking at the regional wall motion abnormalities. Next one, Raj. As I said, like I used the common 4 views. The first, the top left is the parasternal long axis view. So that view gives a good idea, and you can see the metal septal separation, look at the LV function, looking at the opening of the valves. So that's a standard view to start your POCUS. Then move on to the parasternal short axis on the left side top corner, right side. So this is the one of the key views. If you want one view to look at the function, LV systolic function, this is the good view to get. Look at the LV, look at the RV, compare the sizes. And this is the one view where you can compare the valves for the regional wall motion abnormalities. So I highly recommend using the short axis view to assess the global function. Then move over to the left lower end apical 4-chamber view. So there you can see all the 4 chambers. You can see the tricuspid regurg. You can estimate your pressures. You can do your MAPC. You can do your TAPC. And you can again assess your wall motion abnormalities in this view. Then if you don't get any of the transthoracic views, so the subcostal view sometimes may be the only answer, especially in COPD patients with hypoxic. The subcostal view may be the only option, and this is called the subcostal 4-chamber view, where you see again all the 4 chambers, measure the RV thickness, and gives you an idea of everything. Next one. So that's the most important thing in the POCUS. So look for the myocarditis, look for the regional wall motion abnormalities, look for the function. So the challenge when you're doing the cardiac POCUS, sometimes in these COVID situations is patients might be prone. So the AASC had a good image where I didn't put all the stuff here, how to do or getting the expertise in the prone positioning. So that is the only challenge may be encountered, but nothing no different. Carry on with the standard 4 views and add your IVC view when coming to the vascular assessment to look at the IVC collapsibility and the diameter. That gives you an idea about the fluid status. Then if you think the patient is overloaded based on the IVC assessment, you can move on to the next, what is called VEXAS, venous excess ultrasound scan, where you assess the IVC, portal vein, hepatic vein, and renal vein. So they assess all 3, and they give a scoring called VEXAS score that is commonly done by the intensivists, and that's how they conclude whether the patient is overloaded with fluids or not. As the incidence of DVT is very high, thrombotic events, so this is another thing to scan the lower extremity veins, starting from the common femoral, going up to the popliteal vein. They mentioned is a 5-point scan and looking at all the spots and to rule out the DVT. So coming to the cardiovascular, I would say do the good POCUS of the heart using the standard 4 views, look at the IVC, and if another things, do the DVT. If you are very, very advanced, look at the VEXAS. Thank you, Raj. So that's what I can say. You need to use it. It is becoming a common gadget. You get all the 5 stars, and you don't want to cry because you didn't use your POCUS skill.
That's well, I'll leave it there. Thank you so much. We crammed in a lot into this session. There were a couple of other posters we're going to talk about, but I'll leave the links in the comments for the sake of time. I really want to thank all the authors that came on and took time out to present their work. All of us felt bad that you didn't have an opportunity to present it at the meeting itself, but with an audience of somewhere between 500 to 1,000 people watching these videos, it's probably more than you get at a moderated poster session. So it may actually come out better in the end and actually getting more exposure for your work. And I want to thank you guys for talking about point of care ultrasound, not just in the context of what was at the meeting, but in the context of everybody's life nowadays dealing with coronavirus. And I think there's a lot that we're going to learn from this, hopefully, and initiate coming out of this on the other end. And we'll do things better than we did before, so that there's something that's good that comes out of this. Any last thoughts or comments before we wrap it up today?
One thing that was mentioned in the live comments, thank you, Hari, for pointing that out. USABCD.org has made their lung ultrasound module available for free during this time. So it ends at the D.
There's no E up there. Okay, so there's no E. The diaphragm. Here we go.
Yeah. So that's a helpful resource. I don't think they have a module specifically on COVID-19. So if you want to look at the findings specifically for that, you may need to supplement it. But it does at least give you the fundamentals for lung ultrasound. For cardiac, I just want to say, because this is such a prothrombotic disease, really, looking for PEs, looking for or propagation of clot and regional wall motion abnormalities is incredibly important when it comes to determining whether or not patients, what's their prognosis. If it's one thing if their lungs are knocked out, it's another thing if you've caused a significant either viral myocarditis or they've had a significant cardiac event as a result of it. So
one last little plug. ASRA is having a webinar this Wednesday talking about life after COVID. So this is clinical practice in the post-COVID era. And you have to register on the website. So if you see the link I've got at the bottom there, and I'll put it in the comments too, you can go to that link and register for the webinar. I'll be presenting part of the topic there, but we've got several faculty that are going to be talking about different components about how to get your practice back into function in the post-COVID era. And we're going to talk a little bit about ORs, but also about pain clinics. So for those of you guys that are interested, this is the last day I'm going to do the poster moderated sessions, but I will be continuing to do live streams intermittently as time allows. So keep up, and I would love to get other people involved with this and joining the conversation, just talking about what they're doing in their own careers and their own practices. And hopefully we can keep the conversation going as time goes on so that we don't feel so socially distant, even though we're physically distant while we're dealing with coronavirus. But thank you all of you for joining. I know this has been a long session, but I really enjoyed it. I hope you guys did too. And I'll see you again soon in person, hopefully. Thank you guys.
All right.
Thank you.
Thanks,
all.
Raj.
Stay, Raj.